we can go ahead and get started. Hopefully I don't have any technical difficulties today and everything works correctly. Turn off my phone. Well, since I don't know everybody, but if today is your first time with us, like I said last time, I'm just now getting to learn everybody's names. Lindsay did this for a few years. I'm new at this. So if this is your first time joining us, would you introduce yourselves to everyone today? Oh, it looks like pretty much everybody's been with us, I believe.
Good morning. This is Mary Lou Rodriguez. So I'm with Kern Family Healthcare or Kern Family Kern Family Healthcare or Kern Health Systems.
Okay. Are you going to be doing our health equity presentation today?
I will.
Okay, great.
Good morning. My name is Amber Lopez. I'm from Kern Behavioral Health and Recovery Services. I'm popping in as a guest today for the first time.
Okay, thanks for joining us.
And good morning. My name is Cynthia Strange. I'm here from Kern Behavioral Health, also as a guest with Amber to present. Thank you.
Oh, great. Thank you.
Hello, my name is John Salvador. I'm with Aegis Treatment Centers here in Kern County. I apologize. I have a meeting at 10 a.m. For a VA meeting, so I'll have to depart early, but this is my first meeting.
Oh, well, thank you for joining us. Okay, anybody else? And I'm looking. All right, well, our first presentation this morning is from Clinica Sierra Vista. I'm not sure who that is. It's not on my notes. I'm so sorry.
Hi, it's me, Natasha.
Oh, hi, Natasha. Thank you. I'm like, oh my gosh, my notes are not done.
Good morning.
Well, then we'll jump right in and we'll let you, you're going to talk to us this morning about your differential response program.
Yes. Good morning, everyone. Once again, my name is Natasha, and I'm from Clinica Sierra Vista from our differential response program. I am one of the supervisors, so it is 4 supervisors here in Kern County. So I am one of the 3 that is in Metro or Central, in the Central area. And then we do have one more supervisor, which that covers like the Tehachapi, Cal City, and those areas, Beaufort Heights, and all those. And so differential response is a voluntary program that helps supports families, and we get all of our referrals by Child Protective Services. So all of our referrals come from Child Protective Services, and they have to be referred by Child Protective Services to be part of differential response. And so we like to share that because sometimes people call and be like, I want to be a part of differential response. And a lot of times we have to decline them and say, hey, do you have a case with CPS or the Department of Human Services? And so I always like to say Department of Human Services, because when I say CPS, people freak out, right? So basically a little bit about differential response. So once again, like I said, we get all our referrals from Child Protective Services, and a lot of our referrals basically are neglect, child abuse, domestic violence. And so basically what we do is we have 3 paths. So one is like path 1, which is no social worker. So what that looks like, someone probably call in and saw a neglect or abuse, whether it's through the education system, through the hospital, or just us being a great citizen, right? We see child abuse and we can call that hotline, and the responder may take the report and they will determine what path it is. Do it need to be escalated to a social worker, right? And so a lot of our paths sometimes escalate to a social worker. So a path one is just general, it could be general neglect, like, oh, someone probably whooped a child in public, or a child went to school and say, oh, my mommy spanked me, or my mommy hit me, or there's no food in the house. And so, which is definitely reportable because we're all mandated reporters. So that's that path one. And then our path two could be escalated, right? It could be, hey, for instance, like, yes, I actually saw this child being beat, and the child was screaming and just things like that. And so they escalate. And so our case managers work closely with their social worker to get programs. So in in a nutshell, we actually are a referral program. So we refer our clients to outside resources like PG&E, Catholic Charities, uh, Community Connections. Also, for our mountain clients, we definitely refer them to the Resource Center a lot, because we do cover Frazier Park, like I said, Lamont, those areas and things like that, Taft, Delano, Wasco. So we cover the whole Kern County. And so some of our DR struggles that our clients struggle with, we all know housing, unstable housing, trauma. A lot of our clients are repeated trauma. You know, they went through trauma as they were a kid, and now they're in trauma with their children. Unemployment, lack of food, hygiene, substance abuse, domestic violence, definitely lack of healthcare, especially the whole thing that's about to be switching, that will be coming up from those who have health net and then have to switch over to another health system. Child missing from school, we deal a lot with that. Affordable child care, and just lack of parenting skills. And so we do provide resources for those different areas. We definitely, our goal is child safety. That is our number one goal. We have to lay eyes on the children. So we do unannounced visits and we do scheduled visits. And that's just because the severity of each case, and each case is different, right? And so we really take our pride in strengthening the family and increasing the protective factors, which include like coping skills, problem solving, emotional wellness, community support, and family permanency. That is our goal, to have the family stable so the children can stay with the family, and to reduce CPS involvement. And so that's what we basically do. I have a whole bunch of numbers. I'm not going to get into all that. But, and let's see, in Kern County alone, between 2020 and 2021, there were 13,425 Kern County children that experience abuse and neglect. And that's an average of 37 children per day. And this was in 2020, and that was the study. And so in 2020, there were 5 children fatalities, which determined neglect and abuse, which is under the age of 3 and younger. And so that's some of the research that that we saw. And so why DR works and why case managers, social workers refer them to us is because number one, we have compassion. We take pride. We love our clients. We are family focused. We are strength based. We have we do tremendously training and trauma informed. And number one, we are non-judgmental and we have everlasting partnership with the community. And so that is my presentation. Any questions?
I just want to double check and make sure I heard it right, that they can't go through your differential response program unless they're referred to from DHS with
Yes.
CPS involvement. Okay.
Yes. And so once they go through our program, and I didn't mention to say that. So once they go through our program, they may successfully, so it's only like 3 language that we use. So it's successfully, meaning that they completed their goals. And so what we do is when we meet with the families, we sit down and say, okay, here is the referral, right? And the social worker may say, we need X, Y, and Z, right? So we will do the protective factors, see where the family is, because they may not be where the social worker is saying where, they need that, right? So they may be like, okay, they need substance abuse. This is, for example, they need substance abuse and they need legal like some type of legal protection, right? But when we go in there, they may need housing, right? So we all know if housing is the number one factor, all the other goals is going to lack. So what we do is say, okay, we see what the social worker is saying. And so we go in there and say, okay, if we know that housing is an issue, that may be a goal on top of let's do substance abuse. And we'll see if their goals is attainable, because a lot of times their goals are not attainable. Or they may say, okay, we can do all this, and then they don't do it because our programs is only for 6 months, 3 to 6 months. We can hold the clients for like 8 months, but it's really 6 months. And so we work intensively with them. So we may see them twice a month or maybe some clients we have to see every day just because the intensity of what's going on. And so, yes. And so once they're referred to us by DHS, then whether they are successful, whether it's unsuccessful, meaning that they didn't complete their goals, or CNO, which basically mean that we may have did a one-time service, or we can't find them. And so once they find out, like, hey, we were referred to this program, once they're in our system, they can call back and get us. They can call back and get service. And so we do have repeaters, whether they're successful, whether they're unsuccessful, because maybe something came up and they need our support. So, yeah.
Okay, great. Thank you.
You're welcome.
Any questions? No, that was a lot of information. Thank you so much.
Yeah, I try to make it, because my slide is like 21. So I just could do, put it all in like one lump sum, because I know we have other presenters, but yes.
No, but thank you. All right. Well, with that, and if no one has any questions at this time for her, then we will move on to our Kern County Behavioral Health, and they're going to talk to us today about the opioid settlement and what they're doing. So if you would like to jump in and.
I'm going to try to share this presentation. Are you able to see the screen?
No, not yet.
Okay. It says that it's sharing. Let me try again.
There it goes.
See. I don't know if it'll allow me to put it in present mode. Can you still see it?
Yes.
Okay. So, hi, I'm Amber Lopez. I'm from Kern Behavioral Health and Recovery Services. So we are going to talk about the California opioid settlement funds. I'm going to go through the background pretty quickly. So if you have questions, you can stop me. But the point of this presentation is actually to solicit feedback from the group. So that's why I want to hit our informational portion quickly so that there's time to allow discussion from the group. And then I don't want to eat up too much of the time from everybody else. Introductions again, our system administrator is usually with us when we do these presentations. She's not here today, but her name is Anna. And then myself, and then Cynthia introduced herself. She's one of the analysts from our team. So just an overview. So it's been on the news. It's been kind of talked about if you've heard about it, but California joined some national lawsuits against some of the opioid manufacturers. It's not just manufacturers, it's manufacturers, distributors, pharmacies, a couple of other organizations that have been deemed responsible for creating the opioid epidemic. So we've won these lawsuits, we've gotten settlements, we've received funds, and we expect to receive future funds from future judgments and settlements. And what we have to use these funds for is activities specifically to reduce, treat, and abate the effects of the opioid epidemic in our community. So specific to Kern, in 2021, we had 492 drug-related deaths. About half of those were specifically fentanyl related, which, you know, is an 85% increase from the year prior, which is very significant. For Kern Behavioral Health and our Substance Use Disorder Division, 37% of the clients we treat use opioids. It's the most commonly used drug of choice in our system of care. So that's just a little bit of background. With this money, these are some examples of some of the things that we can use it for. It's not inclusive to the things we have to use it for. But we can use it for things like naloxone or Narcan or any other FDA approved opioid overdose reversal medication, training and distribution. We can use it for medication assisted treatment for uninsured or underinsured individuals or other treatment services, screening, treatment, wraparound services for pregnant and postpartum women, expanding treatment for neonatal abstinence syndrome, expansion of warm handoff programs, so helping people transition from different types of treatment, you know, maybe moving from outpatient to residential or vice versa, or from treatment to other community resources. Treatment for incarcerated populations, prevention programs. Prevention programs are primarily focused on the youth population. Expanding syringe service programs, which is a harm reduction model to reduce like STIs. So those are some examples. So that's a little bit of background about the funding. Kern has funds available. It's long-term funding. We expect it to last upwards of 20 years. We receive money each year. So we are focused on underserved areas, rural populations, especially places like the mountain communities, our outlying areas, our minority areas, our underserved areas, our uninsured areas, our areas that don't have services. So what we're looking for is feedback on what these communities need. So we've actually visited Fraser Park. We spoke with Jennifer, I think I saw her here, from Clinica, and she gave us some insight into what's going on in the mountain communities a little bit. And she gave us this resource to speak to you guys and see if you had anything else to offer about what you guys need. So here are some discussion questions to kind of get the conversation going. And we're open for questions if you have any questions for us about how these projects are going to be managed, what it's going to look like, what we can do with it, what kind of projects can be done. And you can tell us what you need and what you'd like to see done with the money. There's a lot of money that can be spread around. So any thoughts? What does your community need? How bad is the opioid problem in your community?
Well, I know that it's a very huge problem up here. And we service a lot of clients that have opioid addictions. I know that we're looking at getting the training for Narcan and be able to be a distributor, since we're located in the heart of Fraser. But I don't think, and I could be wrong, so if I am, please correct me, I don't think there's anywhere up here that people can go for treatment for, like, if they wanted to take what is it, methadone so they have to go off hill. So that's the biggest thing, is where we're located. And if they have to go to Bakersfield to get treatment, by car, you're talking 45 minutes, but most of them, again, if they don't have the transportation, are going by bus. So that can be a whole day event. So I think it's getting the treatment within our area so they don't have to go to Bakersfield to do that. I don't know how that works or how to make it happen.
Yeah, that's one of the problems we heard from a few areas. There's just lack of services in our smaller communities. Are there any other types of resources you would like to see?
I think I would like to see some curriculum at the junior high level, and maybe even some curriculum that deals with, like, the trauma of being a student. My student may not be using, but has family members. So some trauma-informed instruction that deals just around being the child of an addict.
Okay. Do you guys have any prevention activities in the school currently?
We have, like, this week is Red Ribbon Week, so we have a couple people in talking, like the CHP came to talk to our kids. They're in there right now at an assembly. We do have a health unit, but I feel almost like what the state has adopted as far as our curriculum is a little outdated. Like, it doesn't even address, I think that it touches a tiny bit on opioids, but it's really a big focus on, like, not vaping, which my kids need. That's probably where they're starting. That's where we have a lot of problems. And we have vape sensors, and we have, like, Friday Night Live, which is a group where kids go teach the other kids, like, and ways to be involved so that they're not on drugs, and so they don't get in that area group and have other things to do. But my focus here really is keeping the kids as actively involved in programs until 6 o'clock, 7 o'clock at night. That's my goal, but I don't have any kind of, like, solid ongoing throughout the year curriculum.
Okay. Yeah, we Kern Behavioral Health has a prevention team that visits the schools. I don't know if the schools in your area are on their rotation or not, but we can look, because there are some resources that are already available that we can put in that we don't have to use these funds for, that are already there, and then we can add these funds to other things to enhance them.
And we have a TUPE grant, which is which we can use for that, like, that just
Mhm.
designated for that.
Okay. And then I heard, I know you mentioned medication, sorry, someone mentioned medication too. I know there's no medication offered in Fraser or nearby. I think you said methadone specifically.
Yeah.
But there's also no other medications, because there are other medications for, do you think that's something that would be well received in the community?
I think it would help move things in the right direction since we don't have anything up here. Bringing that here would give people that option, because I think right now it's they don't have, you know, a lot of our clients, and the reason we're centrally located in Fraser Park is even before I started working in the office, I didn't realize how many people have to walk to us. And the mountain communities isn't a small area, so some of them are walking very far distance to get to us for like food or hygiene products. So I think that they would be willing, and if they could go to, you know, somewhere up here to get it, whether it be behavioral health or Clinica Sierra, the pharmacy that's open Monday through Friday, something to help them get it on the mountain instead of having to travel may help them, because even those that want to get clean, if they have to work as well, you can't do both, because if they're riding a bus, that's a whole day's trip pretty much. Down and back up takes, you know, 6 hours or so.
Right, right,
So I think having it here would be a big help.
okay. So youth resources, treatment services, medication.
Yeah.
And I know, the first time we visited, we talked about just the fact that there's no outpatient services available at all, in the area. Okay, is there anything else, any barriers? I know there may be technology barriers, I don't.
Yeah, that's gonna be the biggest
Uh,
one, is connection to and having Wi-Fi or cell phone service within the communities.
Okay.
A lot of families, you know, and we're trying to get them signed up and get them the discount, but it's still not high speed, and if it is, it's gonna cost a lot of money. You know, I shared that in the small canyon I live in, if we want AT&T, the fastest speed for AT&T is 1.5. You know, and down in Bakersfield, you know, at 150, and we're at 1.5. So most people can't. So they either don't, they have to drive to like what we call the bottom of the canyon to use their cell phones, to use anything like that that may have cell service, or they have to pay a high amount, and if they're, you know, struggling. And I can tell you my area is very high, just in my area, for the drug use. And you know, you're talking about overdoses. Just on my street is one of the largest fentanyl dealers in our area, and we've had, I believe it's at 4 women die in the last 2 years there.
Gosh.
So I see it firsthand all the time, having to, you know, they don't have service, so I'm the one calling 911 to get them help. So the barriers are there because of our rural setting and just not connected, you know. So many places that say, and you know, I'm not picking on anybody on the collaborative, but a lot of people say we service all of Kern County, but we have found that that really isn't the case, because we are part of Kern County, yet we don't get, you know, a big amount of services. So it's one of those things we struggle with.
Okay. Kevin?
Thank you for the presentation. Good to know some of these resources are coming our way. Is there any consideration to using some of these dollars to outreach to medical professionals to decrease the amount of prescriptions they are issuing every year? The last stats that I saw they date back to 2020 from the CDC, but there were enough prescriptions to opioids given out in Kern County to equal 35 out of every 100 people in Kern County having a prescription. So I guess I don't understand why, if these drugs are so dangerous, why are they still being prescribed at such a heavy level? They're literally making addicts.
Yeah, I've heard, most of the discussion on training is related to training physicians to responsibly prescribe medications to treat opioid use disorder. Because there's so many legislative pushes to limit how they prescribe opioids. So I think it's treated as unrelated problems. Even though it's not. We know that it's not.
Yeah, so they're prescribing drugs to help people get off the drugs that they prescribed.
Yeah, but there's also it's very touchy because the prescribers don't like us very much.
Yeah.
When we talk about this.
I understand this is complicated, but
Yeah,
I
no,
mean,
agreed. Yeah,
100 years ago, they used to prescribe heroin as a painkiller and for many things. And these are worse than heroin, but these are still being prescribed. Like I said, at the rate of 35 per 100 people. Like, that's an insane amount.
yeah.
So just a consideration. Thank you.
So prescriber training is definitely a component of approved uses for the funds. And so that's discussed a lot. And there's been a couple of communities that requested it, but the request is driven from, we need people that will prescribe medications to treat opioid use disorder, and no one here will prescribe those. So the push is to train prescribers to give them the right medications to treat their disorder. And unless they're like trained addiction medicine specialists, a lot of the prescribers are scared to touch addiction disorders, even though that's what their patients are struggling with the most. So there's a gap that needs to be filled. It's easy. It almost seems like it's easier for them to keep prescribing the opioids and keep it at bay than to start treating the other side. And that's the hard part to flip. So it's definitely being talked about. How do we flip? Just, I remember my mom had knee surgery with Kaiser. I think I was like 10 or 11, and they gave her a bottle of 200 Vicodin. This was probably 20 years ago, and that's nuts. Like, that was the way, that was normal. Like, yeah, just take enough to where you don't have to come get it again. And that just, now the culture we're in, you think about that, and that blows my mind that was just so normal. And it was just to keep it until you so you don't have to worry about getting more if you're in pain. So yeah, it's a problem. Any other questions?
I have a comment, Debbie Turner.
Hi.
I would like to strongly agree with the idea of curriculum in the schools. More than 20 years ago, I was responsible with several other people for writing grants that were approved by the Office of Criminal Justice Planning to present curriculum 3rd grade, 6th grade, 8th grade, and then again in high school. And the whole theme was prevention. Prevention pretty much stays the same, regardless of which drug we're talking about. We use part of the TUPE funds that we had, and we're part of the drug-free schools and curriculum to do that. Very widely received by the students, by the staff, by the parents, by the whole community. I would love to see something along those lines that could be implemented up here for the students, so they don't, some of them will anyway, but so that maybe the majority of them walk into life with more of an understanding why not to choose the opiates and therefore lessen the total number over the years. So thank you for the recommendation for our schools to do that.
Debbie, do you think that your schools have the infrastructure to accept a grant and build curriculum like that at this point?
I think it would depend on what was offered. I think that the desire is definitely there. And there are probably more people than myself that would know the answer to that. But we do have some really dynamite principals and a wonderful superintendent who would be, I think, open to pursuing that idea, coming up with a game plan, coming up with curriculum without impacting too much on the teachers who are already overloaded with having to meet state mandates. So if it's made simple and easy, I think that they would be open to that.
Okay. Thank you.
And I think my last comment would be, we also need mental health services up here. There's just not enough places for people to get the mental health services, and that's a lot of times, especially our young people, don't have a lot of places to go to talk to somebody. So to numb or deal with it, they either turn to an opioid or self-harm or drinking, those types of things, because there's, you know, again, being a rural community, we don't have a lot of, unless like Ms. Hansen said, the schools try to keep them busy with sports and with activities, and she's built an amazing program there with her community schools grant for after school care to give them so many options from music to cooking and all of that. But you're still going to have those kids that don't feel like they can get involved because they're battling mental health. And again, the opioid use at home or abuse at home, they feel like they don't have anywhere to turn, even though the school opens up places, but there's just not mental health services. I know so many people that if they're going to take their child to therapy, they have to leave the mountain to do it. So again, we're just so secluded. There's just not a lot of services here.
Thank you.
With the programs that I was able to implement, the three words were prevention, intervention, and positive alternatives. And your mental health comes right in with that intervention. It's such a necessary component. And the positive alternatives, giving these youth up here something to do that is positive and produces great energy and keeps them away from the temptation.
Yeah. And one of my advocates just reminded me, a lot of our health services that are offered up here or mental health, you have to qualify for Medi-Cal. And if they don't qualify for Medi-Cal, then they can't get the services.
Yeah. A lot of the materials allowable for the funds covers co-occurring. So there's space.
On top of that, I think that when somebody is ready to or wants inpatient treatment, it's unaffordable. If they don't, like Misty said, qualify for Medi-Cal, and even with Medi-Cal, I think the cost is more than someone with an addiction, for a lot of people that they can't afford.
Okay.
I know that I've tried to help a couple clients look for inpatient treatment, and there's nothing local. I think somebody was referred to Ventura one time, but even then the cost was a lot.
This is through Medi-Cal?
This particular person was older, so they had Medicare.
Okay.
But I've had looked into things for other clients, and depending on, you know, a 30-day, 60-day, 90-day inpatient treatment, you're looking at thousands of dollars. And a lot of people, that's probably the biggest barrier. It's being able to afford that and being able to detox and move from that to the next step, outpatient, and in between. I know you touched on this, inpatient and outpatient, they need a lot of support. A lot of them relapse as soon as they come out of inpatient treatment.
Okay.
Going back to where Misty said about the whole, some people don't qualify for Medi-Cal. I see in a lot of clients that have full-time jobs and have kids that sometimes they make over just $100 or $50 and they don't qualify for Medi-Cal. And some of these people that have jobs, unfortunately, not all these jobs offer insurance, medical insurance. And so, you know, they're bringing home, let's say, for example, for a family of 3, they're bringing home about almost $4,000. So obviously they're off by like $500, $700 off to qualify for Medi-Cal. And then their kids need sometimes therapy. And I know that some of them, they get it through the school now, thanks to Corey, but what if they want private therapy, you know, or like the parents need therapy, or like if the couples are fighting and they can't afford it? I know that a lot of therapists now do Zoom sessions now, and they do over the phone appointments, but it's unaffordable for the people that can't afford insurance. Just for example, me, I was just barely approved for Medi-Cal about a month and a half ago, but I was denied various times. And my husband has kidney failure, and just with what I make and what his disability, we're borderline and we just barely qualified. But it'd be great if we can get some mental health, maybe through Zoom. That's something that we would be able to offer here at the research center. We can connect people that can come into our office. We can set them up, because a lot of people can't afford internet at their house, or they don't have a computer. That would just be great for the community overall, from parents to kids.
Okay. Thank you, everybody. I don't want to take up too much more of your time, but I will say that if there's any additional feedback that you'd like to offer, we're accepting all feedback on an ongoing basis. Like I said, this is long-term funding. So we've started proposing projects. We're going to keep proposing projects. Whatever we start implementing, if it's not working, we'll change it. We'll keep everybody up to date on what we're doing through forums like this. We'll keep soliciting feedback. If you would like to provide additional feedback or talk to anyone that also would like to provide feedback, we have this QR code open. It will just take you to a form, same questions, and then you can provide ideas, suggestions, contact information to where you can say, I want to know what you guys are going to do with this. Here's my email address. And then when things start rolling forward, and we put out more information on what we're doing, you'll be on the list. So I sent this, Cynthia sent this presentation to, I don't remember who she was in contact with, I'm sorry. If you don't mind sharing this with everybody, that would be great. But thank you guys. I'm sorry I took so much time from your meeting. We really appreciate the feedback though, and we're hoping to do some big things with this money. We've never had money like this before that's not stipulated to Medi-Cal or other grants or things that we have to be very specific with.
Thank you. All right, then we'll move on to, since we've had some time with that and everybody's asked questions or gave feedback, we're going to move on to our next one, which is Kern Health Systems and their health equity teams.
Let me know if you guys are able to see my screen.
Yes.
So once again, I'm Mary Lou Rodriguez. I'm with Kern Family Healthcare, and I am part of the Health Equity Department. So I'm going to give you guys a brief introduction into our department. The context of the presentation and our department is just to identify what we're doing with the Health Equity Department. This is something that is not new. Health equity has been around for many years. There has been different strategies, initiatives, ongoing. Within current health systems, we have had, we're working on MCAS, cultural linguistics, population health management, and many more. We'd like to thank everybody who has already been engaged in making improvements within the health equity area. We understand that this is something that isn't new, but we hope to expand our collaboration and with all organizations and hopes to expand health equity work. Why we're doing this? Well, the DHCS 2024 contractual requirements did include hiring of a chief health equity officer, a CHEO, also creating a health equity office department, along with quality improvement health equity transformation program and a quality improvement health equity committee. We do have the CHEO already on board. Many of you guys might know him, Traco Matthews, and our team has already, the staff has hired. So we're slowly but surely getting all of the 2024 contractual requirements completed. We also have NCQA accreditation. This is also included in one of the 2024 contract deliverables. This represents an ongoing pursuit of excellence within the space. The health equity accreditation is a separate key initiative that we at Kern Health Systems are doing. So not only are we getting NCQA accredited, but also accreditation throughout the health equity department. The KHS strategic goals and values include to improve our MCAS scores and also positively move the needle of other health disparities within our communities. What are we doing to move that needle? Well, we are going to have regular review of quantitative data via disaggregated BI reports, and that's our business intelligence department. That's going to help us bring greater awareness to health disparities, access, and quality. So as Kern Behavioral Health was mentioning, there's a lot of disparities that we may not be aware of, but this is what this forum is for, and we want to make sure that we are addressing those. So we want to make sure that we have these collaborations, we analyze what the root causes are, and then provide training and individualized support to close those gaps. We'll have regular review of qualitative data to enhance listening and increase trust within our employees, our members, our providers, and our communities. We will have monitoring and support. So we will have regular quarterly meetings with our Quality Improvement Health Equity Committee. We'll also submit reports to our Kern Health Systems Board and the Department of Healthcare Services, and formalize cycle of addressing issues and challenges that are more difficult to resolve. Here is just a quick org chart. We do have Emily Duran, who is our CEO, and our CHEO does report directly to her. Like I said, that's Traco Matthews. And then our department is the one highlighted in the little red square. We have Pavan Gill, who is our Health Equity Officer Manager. And then Anna Lester and myself are the Senior Health Equity Officer Analyst, and Vanessa is our Project Coordinator. Here's a picture of us. And then our mission for the Health Equity Office is to improve the health and well-being of our members and communities we serve through the delivery of trusted, high-quality, cost-effective, and accessible healthcare to all, regardless of the zip code, race, ethnicity, preferred language, cultural preferences, or personal history. This is demonstrated through focused, knowledgeable clinical interventions and measures, customized, knowledgeable non-clinical interventions and measures through our human resources, marketing, member engagement, community engagement, and member services, along with our procurement, member-centric evaluations of individual experiences, and strengthening of trust with historically marginalized communities. Some of our objectives for 2023 were to hire staff and officially launch our health equity office, which we have done, along with developing a strategy for our health equity office, and create policies and procedures. The launching of formal Kern Health Systems diversity, equity, inclusion, and belonging program. This is still in the works, but we are finalizing that, along with beginning to identify gaps in care or outcomes due to individual and systemic barriers. We want to develop relevant trainings and interventions to help close those gaps. The design and implementation of plans and measures of success, and the design of regional advisory committees, which we call the RACs. A little bit more on our RACs. This is something that Kern Family Healthcare is focused to improve the understanding of our communities in many of our regions throughout Kern County. So when it comes to the RAC, it is going to be made up of Kern Family Healthcare members and community representatives within those communities. We also are going to want feedback. So with each of these sessions, we would love the opportunity for your region to give us feedback on what's going on, just as we had in the previous presentation with Amber. Give us the feedback. Let us know what is needed within your community, so that way we can help close those gaps when it comes to our RAC meetings. Some external wins that we've already seen is obviously our Kern Health office staff. Like I mentioned before, we already had that representation, and we have had representation within our local and regional equity-focused health consortium. We also facilitated the launch of our local health plan of California CHIO group, initiated monthly meetings with DHCS and the local health plan of California CHIO groups. Below is also a table of some of our advanced and support equity initiatives within our region that is already going on. We will share this presentation with all of you guys as well. If you guys would like to contact us, we have included our health equity managers' contact information, along with our project coordinators' information, email address. If there's anything that you guys have, any questions or concerns, please feel free to reach out, and we're more than happy to help. Thank you.
Thank you.
I'm sorry, I try to go but fairly quickly, only because I know we were limited on time and I don't want you guys to go over.
You're good. Are there any questions or comments that we have for her about the health equity? And I know that they're going to be sending somebody from Kern Family Health to the Resource Center twice a month. So that's going to be nice to have for our clients, to help them get connected to services where we're limited. So we are thankful for that. Okay. If no one has any questions for her, does anybody have anything they'd like to share about their programs and what's happening with you in your organization? We know Kevin with First Five is super busy.
Are you calling me out right now?
No, I'm just saying I know you're busy.
I am
You
busy,
guys got a lot
actually.
going.
Yeah, we I guess I can give an update. We had our 25th anniversary ECE grants window close at the beginning of this month, and we're in the review process. There were some applicants from up on the mountain, so keep posted. We'll be announcing those winners in November.
Right. Does anybody else have anything going in the next 2 months? Because this is our last meeting for 2023, our last collaborative. We won't meet again until January 25th, 2024. So for us, we're getting ready to start our Thanksgiving and Toys for Tots, and our busy season is getting ready to begin. Or our,
Yes,
it's like
I
the
do.
third busy season of the year. Go
Oh,
right ahead.
sorry.
No,
This is
you're fine.
Caitlin from Aging and Adult Services. I'm not sure if any of you are aware, but right now is open enrollment for Medicare beneficiaries. We are going to be having a webinar, I believe this Friday. So I can go ahead and share the flyer for that in the chat. But if you have any Medicare beneficiaries that have any questions regarding their Medicare or possibly even their Medi-Cal, you can direct them to our office. We offer free, unbiased Medicare counseling.
That would be wonderful. Yeah, if you can get us a flyer, we'll get that shared out to our clients and things. And anyone else? Okay, well, then with that, we will end our meeting, and I want to thank everybody for coming and joining us this year throughout all of our collaboratives. And again, we'll see you in, believe it or not, January of 2024. Thank you so much.
Thank you, Misty.